A lovely presentation for tonight. We're going to start recording right now, so if anyone has any objections, just let me know. Other than that, I would like to introduce our moderator of the evening, Dr. Edward Oyang. He is Associate Professor of Surgery, as well as Chief of the Division of General and Gastrointestinal Surgery, and the Director of Minimally Invasive Surgery in the University of New Mexico School of Medicine. And he did a lovely talk at SAGES about GERD versus gastroparesis, which is where I found him. As the topic of this talk, as we kind of mentioned forward, is gastroparesis, which can be a very complex challenge for almost all of us that do foregut surgery. So without further ado, Dr. Oyang, please take it away.
Thank you very much for the invitation. I know this can be a very challenging subject for those of us in clinical practice, and I think the fellows here have done a great job. I've had a chance to pre-screen their presentation. So I would just like to, again, encourage everyone, if you have any questions at any point in time or like to chime in about your sort of clinical experiences or how your algorithms may be similar or differ from what we're seeing today, please go ahead and either raise your hand in the Zoom, put up a question in the chat. We'll be monitoring those actively. Again, we want this to be very interactive and look forward to a lively discussion. So without further ado, I'll go ahead and pass it on to our fellows who will go ahead and introduce themselves and then go through the topic.
All right, good afternoon, good evening if you're on the East Coast. Sorry, I was late. We were just finishing a gastric stimulator, so good timing. I'm Dr. David Leenan. I'm one of the fellows here at Providence Portland Medical Center. Let me just show you the other two.
Hi, I'm Olga Lebedevsky. And I'm Courtney Franklin.
And we're going to be talking about the surgical management of gastroparesis today. Dr. Dunst will be on in a little bit. How do I make this? Excellent. And then there's just our brief biography as well. All right, so for outline for today, we're going to try and dive into the definition of gastroparesis, the diagnosis, the differential, different associations it's been with, and then go through treatment options. And it's a very patient-specific treatment option algorithm. There's non-surgical options, surgical options, and we'll try, show that each patient's a little different and each patient needs a treatment approach tailored to them.
Recording in progress.
Perfect. All right. So gastroparesis, chronic digestive disorder that causes severe nausea, vomiting, early satiety, postprandial fullness, and bloating, with or without abdominal pain, in the setting of delayed gastric emptying without a mechanical gastric outlet obstruction. All right. So this is just my warning slide. This is a chronic problem. This is not something that is curable. The goal of our management is really symptoms, really trying to control our patients' symptoms to make them feel better. The prevalence back in 2009, it was about 9.6 per 100,000 men, and then it's much more common in women, 38 per 100,000 women. And as you can see from the cost, it's becoming more expensive. Back in 1997, aggregate charges about $50 million, but up in 2013, now up to $568 million. And then there's a lot of problems with insurance. The gastric stimulator is not easy to get approved. For a while, it wasn't approved by a lot of insurances and required, it's needed a humanitarian device approval, and you need to, have an IRB and investigational drug investigational device use to have it used in patients. So there's a lot of barriers to getting a lot of the care for these patients. So some processes that it's involved with, that you have to include on your differential or H. pylori, which can cause impaired gastric emptying, accompanied by a reduction in gastric compliance. And it's also seen in the post-vagotomy state, either truncal, selective, or accidental. loss of receptive relaxation and gastric accommodation in response to meal ingestion, leading to early satiety and postprandial bloating. And then this can lead to accelerated emptying of liquids and delayed emptying of solids. And then many other disease processes that you need to be in your differential that could be part of this: diabetes, electrolytes, certain drugs, neuromuscular disorders, IBS, trauma, and other idiopathic causes as well. A couple of different symptom score options. The Cardinal Symptom Index, the Mayo Bloating Index. This is this Cardinal Symptom Index. It's 9 different symptoms on a scale of 0 to 5 that can help kind of figure out what patients' biggest concerns are. Everyone presents a little differently, so it's important to kind of know what specifically they're trying to get treated. And then in terms of imaging study, we'll talk about the nuclear gastric emptying study, pH capsule, whole gut motility study, and then make sure that an upper endoscopy to make sure that a mechanical obstruction has been ruled out. And then a lot of these times, these patients can present with GERD. The gastroparesis can damage the lower esophageal sphincter, and then patients show up, complaining specifically of GERD symptoms, heartburn, regurgitation, dysphagia. So it's important, to make sure, you are assessing whether they have just GERD or just gastroparesis, or sometimes both. So the nuclear gastric emptying study is our gold standard, defined by the Tugas protocol, using radioactively labeled sulfur colloid, standardized meal, microwaved egg whites, substitute oatmeal toast with jam. I've never tried it myself. And then scans are obtained immediately after ingestion of the meal, and then at 1, 2, and 4 hours after the meal. And the measurement of residual gastric contents at 4 hours provides the most sensitive means for diagnosing gastroparesis, as many patients at 2 hours have equivocal results. And then just looking at kind of a little bit of the numbers, retention of greater than 60% of the meal at 2 hours or 10% of the meal at 4 hours indicates an abnormal study. And then there is different varieties in how you can range that gastroparesis: retention of 11 to 20% mild gastroparesis, 21 to 35% moderate, 36 to 50 severe, and then greater than 50% very severe. Another tool which can be useful for working at these patients is the pH capsule or the smart pill. This capsule, swallow it, and then it measures transit time, pH, pressure, and temperature throughout the GI tract. So you get your gastric emptying time, your colonic transit time, your whole gut transit time, and then antral and duodenal pressure patterns as well. And a study done in 2007 showed that using either this capsule or the nuclear emptying study showed equivalent specificity and sensitivity. So both tests can give you good information. And then this is just basic the ACG clinical practice guidelines from 2002 as just kind of a slide if you're looking for kind of a summary of everything we're going to kind of touch about today. So non-surgical management, per usual, got to start with simple things.
If you don't mind me interrupting you again, I'm just going to try to stimulate some conversation here because, I think all of us recognize, gastric emptying study is a sort of one of our, if you will, standard tests. With regards to your pH capsule smart pill versus your cardinal symptom index, do you, at least in your practice, routinely do all 3 of the above? Do you weigh one more than the other? How do you choose to integrate sort of the questionnaire and adjunct studies in addition to a GES study?
So the symptom index is part of kind of a lot of the questions we ask patients when they first come to our office, because you're trying to tease out what specifically they're asking about. And a lot of times we have patients coming in with GERD symptoms. So they're talking about heartburn, regurgitation, but then we really need to tease out, are they having atypical symptoms as well? So that's where we kind of start asking them more, well, do you get bloated? Do you get early satiety, nauseous, vomiting, things that aren't, something typical of GERD itself? So those are kind of the follow-up questions we, in our review of systems, we ask all our patients. And then based off their answers would determine whether they need a gastric emptying study or not. It would be our first step, because at the moment they talk about bloating or early satiety, that's when, you don't want to be treating their GERD and ignoring their gastroparesis. So it's, it all comes from a good history, whether we need to do, the gastric emptying study or not in the patient population that we see, at least.
So do you formally do your symptom index for everybody, or is it more based off of your just, again, HPI and kind of getting most of those questions answered? I don't know if that was something routinely you do either for data collection purposes or anything else like that, because I can't say
For
that
for data collection purposes, we have, they fill out a questionnaire before they come to the office. And that includes most, if not all of those things. I don't have it in front of me, but we usually review that before the surgery and then, before, talking to the patient. And then after talking to, once we talk to the patient, just re-reviewing those things, be like, hey, just, you said no, but any of these other symptoms, and that can help kind of guide our next steps.
Gotcha. And with the smart pill, would you say there's a certain percentage of your patients who get those also, or is that also variable depending on combination of GES and symptoms?
That I've seen much less in our practice. That would really depend on what, I think that would.
It's just something that I've never actually done in my practice. So that's just a little bit curious, if it's something I should add to my own clinical armamentarium, or if anybody else has thoughts or comments based off of that.
One of my colleagues is saying that if they're not all patients have access to the gastric emptying study, so sometimes the smart pill can be an alternative to get the same data we're looking for. So,
thanks.
All right. So, so back to non-surgical management. Always want to start with simple things first before we get more invasive. Modification of diet, environmental factors, starting with multiple small, simple meals, low fat, low fiber, or a small particle diet, things they can kind of squish with a fork. And then blood sugar control their diabetes, and then avoiding medications that affect gastric motility, opioids, calcium channel blockers, TCAs, dopamine agonists. And then the medications, metoclopramide, dopamine antagonist, stimulates antral contraction, but has that black box warning of tardive dyskinesia, especially after I believe the warning says after 12 weeks of use, patients are at risk of developing tardive dyskinesia. And then erythromycin is a motilin agonist, stimulates fundal contraction, but also has the side effect of QT prolongation and ventricular arrhythmias. And then antiemetics and antacids are useful for symptom control as well. So let's transition over to surgical interventions. And we're going to switch up one quickly.
Okay, hi everybody. So now we're going to talk about surgical interventions for gastroparesis. The first one is the Gastric Simulator. This can be used for refractory, idiopathic, or diabetic gastroparesis. The electrical leads are placed into the antrum laparoscopically and then connected to a subcutaneously positioned stimulator that delivers high frequency, low energy current. This requires general anesthesia and it's an outpatient procedure. Maintenance after the operation, the impulses in the battery need to be checked every 3 months and changed in the clinic as needed. And the battery has to be surgically changed every 5 to 8 years, depending when it basically dies. Complications, erosion of the leads, infection, bleeding. The device can move around, which can cause pain, and also possible bowel obstruction. This has a 60 to 80% success rate and a low morbidity. Currently, there is multiple nationwide problems with reimbursement and insurance approval for the stimulator. So that's why some centers and I guess in places where they don't commonly do this, you're probably going to be seeing this less and less. In this paper that looked at gastric electrical stimulation for medically refractory gastroparesis, this is the results from this showed that 50% of patients will achieve an 80% reduction in vomiting. And then in the phase 2 results, 50% of patients will achieve another 80% reduction in vomiting, and greater than 70% of these patients will achieve a greater than 50% reduction. And the symptom severity index significantly improves. Nausea and vomiting in patients with diabetes improve better than in patients with idiopathic gastroparesis. So the recommendation from this paper was that nausea and vomiting in patients with diabetes mellitus improve better than in patients with idiopathic gastroparesis with placement of a gastric stimulator, which is something to keep in mind with your treatment algorithm and what exact patient you have in front of you. Next, let's talk about laparoscopic polaромyotomy. This requires general anesthesia, a 1 to 2 hour inpatient procedure, and the length of the stay is usually 1 to 3 days. You need to get an upper GI or an external esophagram prior to starting a diet. Then we recommend a liquid or puree diet for at least 2 weeks post-op, and to recheck a gastric emptying study 3 months post-op. Complications include obstruction, leak. For some patients, it just doesn't work, doesn't help their gastroparesis. Infection, bleeding, or dumping syndrome. And just quickly to review, this is when patients can get symptoms of flushing, dizziness, tachycardia, nausea about 20 to 30 minutes after eating due to rapid delivery of carbohydrates and osmoles into the duodenum. The initial treatment for this is dietary modifications, so small, low carb, low fat, high protein meals, and to avoid sugary drinks. If this is refractory, octreotide can also be given. So pyloroplasty has about a 70 to 90% success rate and also a low morbidity. In this study at our institution, they looked at laparoscopic and endoscopic pyloroplasty for gastroparesis. So let's look at 28 patients that had pyloroplasty alone and at 3-month follow-up. 83% had symptom improvement. And at 10-year follow-up, this was on 15 of the 28 patients, 80% sustained symptom improvement, and 6 had an additional surgery for the gastroparesis, including gastric nerve stimulator, PEG, or J-tube. So now I'm going to go over some of the steps for laparoscopic polaroplasty at our institution. So the first step is creation of your gastroduodenotomy. And we do this with a 2-Rasper technique, also having to mobilize the duodenum first. And basically you can either push or you can use electrocautery to mobilize the duodenum. I'm just going to go ahead. So here, finishing the mobilization. Now indicating and finding where our pylorus is. Is that done? We grab the pylorus on either side with the grasper. And now we do our creation of the gastroduodenotomy, and we like to use the harmonic. And the 2 graspers on either side of the pylorus here help to avoid frame shifting or backwelling through the duodenum or the stomach.
Those adhesions were from prior cholecystectomy, looks like.
Yes, from that patient, yes. All right, so we're creating that. And then we want to make sure that you make this big enough so that you're seeing the pylorus below you and making sure you're actually getting through the pylorus. I'll go ahead here. And in this step, this is an additional technique that we do with a 1 suture technique, which allows that we place the suture at the top of the pylorus and then use that to retract instead of the 2 grasper technique.
Have you found one to be any easier or technically advantageous than the other, either for alignment or anything else?
So I think a few of our attendings would say they just prefer one over the other. So that's why we're taught both ways. And again, opening basically in the middle and using the suture and another grasper to avoid frame shifting. All right, and then I'll progress ahead. Okay, so now we're going to start with our transverse closure of the gastroduodenotomy. So we like to place a suture in the middle. This is the first of two techniques, and this avoids frame shifting again to make sure that you're actually closing this transversely and approximating your ends.
So we have a question in the chat that says, do you use an EGD scope as a calibrator or for exit endoscopy?
We use it at the end.
How about have you guys started incorporated any kind of impedance telemetry for this, like pre-op or post-op, kind of like POEMs or for like the GPOP endoscopic version?
Yeah, so just recently starting to do that for gastroparesis and for the pyloroplasty.
Do you like it? You're gonna put who you use in your practice?
I think so. I've mainly been using it for more of like the poem type of things like that and for achalasia, but I definitely found it useful, so I'll probably be using it for this as well. And we like to, after you're placing the middle suture, do a two suture closure with running on two different ends.
So did you say you
Okay,
are
yes.
using flip for these pyloroplasties?
I think they recently started using them. I myself haven't used the flip during the pyloroplasty. We've mainly been using it for achalasia and for poem type of things.
I was going to say,
I
because
know
if you're
that
cutting
these
all
were
the way
recent-
through, you're cutting all the way through.
Yeah, I think it's more of a pre.
Unless you're using for GPOP or, GPOM,
Yeah.
whatever you want to call it.
I'll just forward that here. And then we use a VLOX, so just making sure at the end, when you've gone past your point, that you lock the suture and then come back a suture to ensure that it is actually locked.
You say you scope at the end. Is that with the leak test for leak test purposes or for just looking at the pains?
Yeah, leak test, and also just to make sure we didn't backwall anything, it's actually open, things like that. So yes, this is the second running suture, always suturing away from yourself. And then this is the other technique, which is they just use a single running suture instead of the two. Again, using a VLOC. All right, I'll go ahead.
And
This is
again,
here,
single versus,
closing.
I'm sorry, single versus two layer closure is just practitioner dependent.
Yeah. Yeah, so then again, we do endoscopic leak test here using our suction irrigator, as well as, like I said before, to make sure that we didn't backwall anything, it's actually open, and that the closure looks appropriate. So that looks good, and then we can go to the end, and this is basically what it should look like post pyloroplasty wide open, nothing backward.
We have a question in the chat that says, what do you think about flip before pyloroplasty to determine who actually has a pyloric problem before doing the operation?
Yeah, so I think that's what I was alluding to before. It's not, you wouldn't mainly do it after it because you're cutting right through the pylorus. It should be, null. But doing it before, I think, can just help confirm that your diagnosis and what you're doing is going to hopefully be appropriate for the patient. Okay, so just going over again the key principles: avoid frame shifting, work on the gastric side to avoid going in blind. The grasper technique refers to holding the pylorus on both sides to prevent frame shifting. A longitudinal pyloromyotomy, don't be afraid to go big, at least 1 to 2 centimeters on each side. And then close transversely. Use a suture in the middle of the incision to help avoid frame shifting, through V-lock or Vicryl as seen in the video. And then upper endoscopy in the operating room after closure to ensure patency, and then open backfalling happened that would cause obstruction, or also ensuring there's no leak. So next we'll talk about endoscopic pyloroplasty. So this requires general anesthesia. It's a 1 to 2 hour inpatient procedure with an overnight stay. We do recommend rechecking gastric emptying study 3 months preoperatively. And the long-term data is unknown. All this is becoming more common over the last several years. Complications can include perforation, leak, infection, bleeding, obstruction, or failure of symptom relief. And this is a study done at our institution back in 2015 with looking at oral endoscopic pyloromyotomy, also known as POP. And it was done 8 years ago as an initial study. And they looked at 7 patients that had endoscopic pyloroplasty. 4 of these had a concomitant application, but they looked at them for 6-month follow-up and looking at symptom scores and also a gastric emptying study. And they found that symptoms resolved or improved in 86% of these patients. Okay, I have this link up.
As we're loading up that video, there's a question about the what's the group's experience regarding pyloroplasty versus GPOP plus gastric stimulator?
As far as pyloroplasty plus gastric simulator, I don't think it's going to do that. More a CTIF, but that's not even having anything to do with gastroparesis. Yeah.
Any of the faculty that want to chime in as well, if you have experience, you want to add
I don't
your
do
input?
gastric stimulators, so I don't have any experience in that realm. I could call out Dr. Revis, who's over there.
I do know we had one patient who had a gastric stimulator. It somewhat worked for her intermittently. So we did go ahead and do a laparoscopic polaroplasty on her and we left her stimulator on after the procedure. So she had basically refractory almost to the stimulator, but it did work and she wanted to keep it. And we did that polaroplasty and I saw her, 4 or 5 weeks after that and she had great symptom improvement. So.
I mean, we can't really say we have comparative data of pyloroplasty plus stimulator versus GPOP and stimulator. Those numbers are just too small. And this patient population, as you all know, is far too heterogeneous to really be able to make those calls. And Courtney and Olga will follow up with this. It also depends on some of the logistics regarding these patients. Patients with a really hostile abdomen, you want to avoid laparoscopy. The GPOP would be helpful in that circumstance as an approach. And patients who live 1,000 miles away that can't get here for frequent adjustments of their stimulator, you don't want to be putting in a stimulator for someone who's has to get on a fixed wing aircraft to get over here every month for adjustments, those type of things. So we have to kind of craft the treatment based on a lot of the not only patient disease factors, but also the logistics around their personal circumstances.
Thank you.
Carry on, Courtney.
Yeah, so this would be our endoscopic oral pyloromyotomy. This is from our institution.
A condition characterized by delayed gastric emptying and a constellation of symptoms including nausea, vomiting, and early satiety is a debilitating condition. Pyloromyotomy has been shown to be a safe and effective treatment option, but is associated with surgical trauma. Endoscopic submucosal pyloromyotomy may improve gastric emptying while providing the benefits of a natural orifice procedure. This video demonstrates the technique of endoscopic peroral pyloromyotomy. We have performed this procedure in 4 gastroparetic patients with intractable symptoms not responsive to medical treatment. The procedure utilizes the submucosal tunneling technique previously well described as part of the FOAM procedure for the treatment of achalasia. The procedure is performed in the operating room with the patient in the supine position. Following a diagnostic EGD, a long overtube is introduced into the stomach. A submucosal injection is then performed approximately 5 centimeters proximal to the pylorus along the greater curvature of the stomach. A mucosotomy is then made using a TT knife at the apex of the mucosal wheel. A biliary extraction balloon can then be used to facilitate entry into the submucosal tunnel and may help reduce the size of the required mucosotomy. Cautery is now used to perform a sharp submucosal dissection. The dissection plane is at the junction of the areolar submucosal tissues and the circular muscles of the stomach, as to minimize the risk of injury to the gastric mucosa. The dissection then is continued distally up to a short distance onto the duodenal aspect of the pylorus, where the pyloric ridge flattens. Hydrodissection using a biliary extraction balloon can facilitate the dissection in areas where the tissue planes are more adherent. Checking the intraluminal view during the dissection can confirm the direction of the tunnel and can reduce the risk of spiraling. Once the submucosal tunnel is complete, the myotomy is started 2 centimeters proximal to the pylorus. The circular muscles of the pylorus are divided using electrocautery. The longitudinal muscle layer may be quite thin, in which case the serosa of the gastric wall may be visible. The myotomy is then carried antegrade up until the point where the pyloric ridge flattens. Great care should be taken during this portion of the procedure, as the duodenal mucosa may be nearly perpendicular to the myotomy plane as the duodenal aspect of the pyloric ridge is reached. If an unintentional mucosotomy does occur, simple closure with clips or an endoscopic suturing device can be performed.
See, there's a question in the chat. Are you using an angled or straight end cap?
That one's straight.
At the conclusion of the case, the mucosotomy is reapproximated using a series of clips. An upper GI study is ordered on the first postoperative day to ensure that there is no leak and that the gastric outlet is patent. As we have had one patient present with a bleeding ulcer postoperatively, all of our patients are now discharged on proton pump inhibitors for 6 weeks. 3 months following the procedure, an upper endoscopy is performed. The pylorus is assessed to ensure that it is widely patent and that all the mucosotomy sites have healed.
Okay. So just going over again the key steps of endoscopic pyloroplasty. Do a diagnostic EGD first, just to evaluate your anatomy, and see if there's any other pathology first before you make your incisions. Make a submucosal wheel about 5 centimeters from the pylorus along the greater curvature. Make a mucosotomy at the apex of the mucosal wheel. A biliary extraction balloon can be used to facilitate entry into the submucosal tunnel and decrease the size of the required mucosotomy. Use cautery to make the dissection plane, and this plane is at the junction of the area of the areolar submucosal tissue and the circular muscle of the stomach. And this specifically is done to minimize the risk of injury to the gastric mucosa. Continue the dissection distally to beyond the duodenal pylorus. You're going to see where the pyloric ridge flattens, and continue to use the biliary balloon for hydrodissection. Confirm the direction of the dissection by intermittently inspecting the interluminal view. So that means coming out of the tunnel you made, inspecting that you're going in a straight line, that you're not making a trajectory anywhere that you don't want to be, and then go back into your tunnel. Start the myotomy 2 centimeters proximal to the pylorus. Use electric powder to divide the circular muscles of the pylorus, and continue antegrade past the duodenal pylorus where it flattens. And close the submucosa with clips or endosutures once complete. And we do recommend upper GI post-op day 0 and the EGD 3 months postoperatively, which you can see the keyhole deformity of the pylorus, which we saw on that video. And to reiterate what Dr. Robertson said before, how do you decide between laparoscopic versus endoscopic pyloroplasty? So laparoscopic is better suited for a non-hostile abdomen. Surgeon preference, if they are skilled at this, they can do it in 10-15 minutes. If performing with other laparoscopic procedures, and if they can tolerate insufflation with laparoscopic equipment. Endoscopic pyloroplasty, you want to consider this more patients with a hostile abdomen. Maybe they have a lot of adhesions, they've had a lot of previous surgeries, XLAPs, etc. Patients that can't tolerate laparoscopy, but they can tolerate endoscopy. And again, surgeon preference or experience.
Before we continue, we have a question from the chat. What is your protocol for pain management after GPOP, and do you use PPI afterwards? It sounds like you use PPI pretty routinely based off that ulcer from the one patient. What about for pain management?
For pain management, we normally do liquid oxycodone just for 2 weeks after, along with gabapentin.
Gotcha. And currently in your group's practice, what do you think the percentage is of lap pyloroplasty versus GPOP? Is it skewing one way or the other, or again, is it pretty much completely practitioner dependent? Are people transitioning one way or the other? Any sort of general trends?
Yeah, I mean, I've been here for like 4 months, but I've seen mainly laparoscopic. I think I've seen one. Dr. Roberts probably answer this more, but I think it's surgeon preference, but as well as what patients you have and what they would, benefit more from.
So I can interrupt. Sorry. This is Christy Dunes. Sorry, I was late because I was putting in a stimulator, ironically enough. But yeah, they don't really know the trends. I think we did a lot of endoscopic pyloroplasties or pyloromyotomies in I think 2013, 14, 15. And just kind of, I don't know, got away from it for no particular reason. And so right now, we probably do 20% pop and 80% pyloroplasty for no real physiologic reason, except for that a lot of times I'm doing it with another laparoscopic procedure. So I'm putting in a J tube, I'll put in and do a pyloroplasty, or or putting a stimulator to a pyloroplasty. If there's nothing else that you're doing and the patient has favorable anatomy, a pop is great, you know, GPOP.
Great, thanks.
So the next surgical management option is a decompressive G tube. A lot of the patients suffer from bloat. And so this decompressive G tube can help with a lot of those gas pains. It's an outpatient procedure, not typically permanent, can be taken out after the initial 4 to 6 weeks. Some of the complications can be tube migration or dislodgement, infection, and obviously discomfort and lifestyle limitations with the presence of a tube. Another option is a feeding jejunostomy. It's typically in patients who are losing weight. They can't maintain their weight due to the gastroparesis. Again, it's can be done as an outpatient procedure, typically under general anesthesia if you're doing open or laparoscopic approach. This is used to bypass the stomach to provide nutrition with the aid of a continuous pump. Again, this is hopefully temporary, but some patients with severe gastroparesis may end up having these tubes lifelong for recurrent symptoms. And complications are similar to the G tube, but they can be more severe. Just because with the J tubes, they're very small caliber, so they can be messy, they can clog, have a lot of erosion or skin complications, and so they're not they can definitely have a lot of complications and discomfort. And I'll show you a video of how we do. Okay. Yeah. Is this one? All right. And I'll show you how we do the laparoscopic jejunostomy tubes here. This is our setup. We use 3 5mm trocars, a suture passer, varus needle, needle introducer, guide wire, peel away sheath, 5 absorbable monofilament sutures, a 12 French J tube, and a 30 milliliter syringe. And this is a positioning and trocar placement. You want to tuck the right arm for the camera driver. The surgeon puts their left hand in the epigastric port, and then the right hand in the right lower quadrant port, and the camera goes, or sorry, right lower quadrant port, and the camera goes in the right upper quadrant.
Are you always doing a decompressive G with the placement of the J, or are they exclusive?
No, not always. We don't always do them together. Typically, this is for patients who are not tolerating PO and need additional nutrition supplementation, but we don't always do them together, just kind of based on their symptoms.
Yeah, the typical, let me interject there. The typical indication for a decompressive G tube is temporarily if somebody is having a pyloroplasty and a fundoplication at the same time, and they tell us that they get their symptom pattern is that they're so bloated they look pregnant. If they are a candidate for a fundoplication pyloroplasty, they often will do well with a decompressive G tube for the first 3 months or so. Most decompressive G tubes are temporary. But in some patients that have pretty severe disease, then they prefer to keep them. So That's the indication.
As far as the placement of the J-tubes, you want to consider any future surgery that the patient might be having. So if we plan to have future upper abdominal procedures, you want to place the J-tube to the left of midline below the umbilicus. And then if they have future lower abdominal procedures, then you put them above the umbilicus. So that's where we prefer to place them. First, use a finer needle to avoid the epigastric artery. Then you want to select the appropriate location. So you at first identify the ligament of Treitz, and you want to run it down to identify the most proximal bowel that will reach the abdominal wall, but will yield the most nutritional value. So you don't want to go too distal, but obviously you have to reach the abdominal wall. We use a trans-abdominal suture passer to secure the small bowel to the abdominal wall. And I'll pause here in this slide just kind of to explain this. We create a suture square on the anti-mesenteric portion of the small bowel through a single incision where the jejunostomy will go, and you create a square with the sutures like this.
So actually, maybe in the interest of time, because I think we have to end at 4 o'clock, is that correct? Maybe I think people are very interested in sort of algorithms of management. So maybe if we could actually proceed on to some of your other decision-making points, and then if people are interested in seeing some of the videos, we can have people stay on or things like that. But, we have, for example, a question right now in the chat: who are candidates for fundo plus pyloroplasty? I think you're going to talk a little bit about anti-reflux surgery next. So why don't we transition into that, go through some of these other decision-making points, anti-reflux surgery, gastrectomy, and then because I think that's kind of where people want to get some thoughts and have some discussion. And again, we can show the videos afterwards if people want to stick around.
Yeah, and we have included all the videos at the end too if we run out of time. And this is just a summary of all the steps for a placement of a laparoscopic J-tube. So one important thing to know is that chronic gastroparesis can destroy the lower esophageal sphincter. And some of these patients may present with chronic reflux and other GERD symptoms. These patients should be worked up for GERD, and oftentimes they may require both anti-reflux and gastric emptying procedures. Anti-reflux surgery alone with mild gastroparesis can improve gastric emptying, but the patients that have severe gastroparesis, pyloroplasty should be included. So this is for as far as anti-reflux surgery, it's under general anesthesia. It takes about 1 to 2 hours. And again, in conjunction with pyloroplasty or alone, it reinforces the valve to stop the reflux. And we use the fundus to decrease the gastroparesis symptoms. Postoperatively, these patients may take anywhere between 2 and 12 weeks for normal diet texture to return. After surgery, due to the swelling, some patients may experience dysphagia, which is usually temporary. One important symptom to discuss with them is the inability to belch or vomit, which can be present in a lot of these patients. And in patients with gastroparesis, this can cause even more bloating. 25% of patients have diarrhea when paired with the pyloroplasty, but this typically resolves. And bleeding infection as with any procedure. So in a study done here at the Oregon Clinic in 2009, they look at outcomes of Nissen fundoplication in patients with GERD and delayed gastric emptying. Here's a graph of the patients that were included. There are some that with no delayed gastric emptying all the way to severe. The patients that had no symptoms of delayed gastric emptying or up to mild got a Nissen alone, and those with severe had a Nissen and pyloroplasty. So at the follow-up of 21 months, there were no differences found between the two groups regarding relief of reflux symptoms or objective control of acid reflux. Dyspeptic symptoms were improved in the delayed gastric emptying group. And postoperatively, the gastric emptying time normalized in 88% of the patients. And postoperative objective outcomes were also no different between these groups, and patients with a Nissen fundoplication who did not have delayed gastric emptying symptoms. This is kind of a graph showing the differences in the symptoms postoperatively in these patients. So the delayed gastric emptying does not affect outcomes of gastroesophageal reflux disease following Nissen fundoplication, but patients with delayed gastric emptying have more postoperative gas and bloat and or nausea when compared with patients that have normal gastric emptying. And a lot of these symptoms can be corrected with the addition of a pyloroplasty.
And one thing I would add on top of it, sometimes when I have a patient who has a large paraesophageal hernia, I think, when you have a lot of stomach up in their chest, I don't know how valid a gastric emptying study is at that point. So for those patients who may exhibit a lot of GES or type symptoms who have large para, my preference is to typically do the paraesophageal hernia repair first, because a lot of those patients will have gastric atony from that stomach being herniating up in the chest for such a long time. And then if they still have symptoms afterwards, you can still always do a secondary pyloroplasty afterwards. So now if they have a, if you will, smaller type hiatal hernia and have significant gastric emptying issues, then those are the ones I agree. Maybe I consider doing more of a simultaneous procedure, but for the big paras, I usually will do the para first and then see how they respond, because frequently a lot of them seem to get better once their stomachs are back in the normal position.
Yeah, that's a great point. We do not recommend gastric emptying studies in patients who have a paraesophageal hernia repair. So when we're talking about concurrent procedures, these are hernias a couple centimeters in size. And patients generally, their primary, this study, the patient's primary complaint was GERD. 1/3 of them had gastroparesis. And we did the study under the impression that we thought a fundoplication will improve it enough for the mild pains or minor gastroparesis patients, and found that actually they'd probably do better if we did a pyloroplasty on them, but it's a different set of patients than a paraesophageal.
Okay, we'll switch gears and next talk about gastrectomy, which is kind of the final treatment step in management of gastroparesis patients. So in this paper published by the Oregon Clinic in 2014, this was a prospective database which was queried for gastrectomies performed for gastroparesis from 1999 to 2013.
Oh, Olga, I think they wanted to get to your algorithms. Can you just?
Oh, yeah.
Can you just want to skip forward? Yeah, they want to.
I think we're down to our last 5 minutes here.
Yeah.
So I think we recognize that, for example, if I have a patient who's morbidly obese and has severe gastroparesis, you do the Roux-en-Y gastric bypass kind of along those lines.
Exactly.
So again, different beasts than what we're considering it typically. So let's see here. Yep.
So go to the algorithm. Don't you have, did you take that out? Okay.
It wasn't here, I don't know. Hey, Courtney.
Don't worry about it.
It was in here, but let's see. I think it was in one of the earlier slides.
Okay.
1 second.
Yeah, that's fine. That's fine. So Olga, then why don't you tell them how you would, you have a patient with gastroparesis and you have all these millions of options. How do you think about it?
I mean, I think you just have to take their symptoms into consideration when you're deciding what surgery they'll have. So if they're primarily complaining of nausea and vomiting, you may do a gastric nerve stimulator. They have bloating and GERD, you can do pyloric interventions. And then if you've tried all the other things and they still have terrible symptoms and severely delayed gastric emptying, that's when you'd consider a gastrectomy.
Yeah, I think again, for the sake of time, since we didn't really get to get a lot of the discussion, I think it's a very individual decision. But one thing that I encourage anyone who's on this call probably has a little bit of interest in gastroparesis, and so I would love to encourage everyone to look at this theory in their patients and see how it develops. Because a few years ago, one of our fellows reviewed about 300 patients that had gastroparesis and looked at all the things. So we were trying to find trends to like, how do we differentiate between patients who have pyloroplasty, patients who have a gastrectomy, whatnot. We did find that it looks like it might become significant in the next few years, is that if patients have severely delayed gastric emptying, so over 50% at 4 hours, those were the ones that tended to fail pyloroplasty and stimulator. And so given the amount of morbidity that a gastrectomy has, if you do a full gastrectomy, especially after a pyloroplasty, we've been moving toward a more gastric bypass approach for those really severe gastric emptying problems. And it seems to be working out, but more data needs to be collected. A lot of questions that you all have is, what's the deal with EndoFlip? Should we be using EndoFlip to identify patients that should have a pyloric intervention versus stimulator? And that data, all I can tell you right now, is being accumulated. Some of you may know more than I do about it, but we are trying to establish normals, trying to establish the normal protocol. Do we do a 60 cc fill or whatnot? But if that technology proves useful, that will be really, really great. Because the biggest thing with gastroparesis is this is a heterogeneous group of patients. And if we can tailor these surgeries to their pathophysiology in any better way, it will be really great. So sorry to kind of upend you, Olga, but I know that the time was running out and they had some questions.
Yeah, and actually there's a question kind of following up for Dr. Cohn out there. So it says, gastroparesis symptoms do not correlate with gastric emptying, which I think we recognize. Says stimulator does not affect emptying. Pyloroplasty promotes emptying. What is your definition of treatment success, and why do you think it is achieved?
So yeah, go ahead, Olga.
I mean, I think a definition of success would be improvement in their symptoms overall and improvement in their quality of life.
Yeah, I think we know with a pyloroplasty, we can normalize their gastric emptying study about 80% of the time. And they're not magically cured. That's why it's difficult to correlate the magnitude of gastric emptying to their symptoms. So we're just trying to improve their quality of life. It's a hard metric, as you can imagine.
So is the takeaway here, if you have a patient with gastroparesis, we should send them to Portland?
Oh, that is hilarious, because when Amber Shada gave a talk on her 300 patients that she looked at, that was what everyone left. I think it was a DDW, and everyone left the room going, Amber, we're just sending all of our patients to you in Wisconsin. So yeah, send them to Amber.
Yeah, I see Amber is actually logged in here. So if you're,
Amber, are you on?
Yeah, I see you're on there. So depending on where you are, don't send them to New Mexico. No.
Send them to Amber.
It's harder to get here than it is to get to Portland. So if you're on the East Coast, Wisconsin's closer to you. If you're on the West Coast, Portland's a little closer. Perfect. Are there any additional questions from the audience? I know we're running a couple minutes over, but any additional questions or comments from anybody in the audience?
I'll say, Amber, I love you. Bye.
Excellent. Thank you all so much for joining tonight. If you do want to stick around to watch some more videos, please, we'll keep the room open. Otherwise, thank you very much, Dr. Yang, for being our moderator. Our next talk is coming up, and the topic is cervical and thoracic esophageal perforation. Will be given on January 16th by the fellows from the University of Missouri. So please watch your inboxes for those invites. Otherwise, thank you so much for joining us, and hope everyone has a great night, and see you next time, and happy holidays.
Thank you for having us.